Welcome back, Care Partners. It's episode 3 of Memory Care with Teresa. Thanks for being here. We have an exciting show for you today because we're bringing in our first guest speaker. So I'm going to just cut to the chase, tell you about Marion Kyner. Well, she's a friend and colleague, I'll tell you first up, but let me get official. Marion is an advanced practice nurse and a psychiatric clinical nurse specialist with over 40 years of experience in nursing. She worked in a senior care community setting for 15 years. She's a certified independent trainer and coach in the Positive Approach to Care model by Teepa Snow. Currently, she has a private practice in dementia care in the consultation and is an adjunct faculty at Longworth University Department of Nursing in Farmville, Virginia, and a clinical instructor at the University of Virginia School of Nursing in Charlottesville, Virginia. Just wow right there, right? She's passionate about changing the culture of how nurses provide care for patients with dementia. She's a community volunteer with the Alzheimer's Association and Dementia Friends. She has 2 adult daughters, a son-in-law, and a new granddaughter born in December on the 26th. She lives with her husband in Cumberland, Virginia. Welcome, Marion Kyner. Thanks for being with us today.
Well, good morning. Hi, Teresa. Thank you for inviting me. I'm happy to be here with you.
Of course. We're so excited for you to be here. We're going to jump right in because we only have 30 minutes and I could talk to you all day about what you do and how you do it. So first, just tell us about working at a care community. Was it a nursing home?
Well, I worked at this care community in rural Virginia. It was the best one in the area. It was a full spectrum. It had apartments, senior apartments, assisted living, skilled rehab, 2 skilled rehab units, and long-term care. And they ended up developing a memory care unit as well. So I originally was a nurse manager there on the rehab unit, and then kind of morphed into a psychiatric clinical nurse specialist role. I was basically their mental health provider. Very unique position to have a mental health person on site to work with residents and families, and also with the staff. So I was doing that for over 10 years.
Well, I'm sure you were a huge asset there, just bringing all your knowledge there. Well, and your passion for these people. And I think you and I find that very relatable. We really want to go defend these people that can't always defend themselves and get labeled or misunderstood. And but what was it like teaching the nursing staff, about dementia? How'd they receive that? Did they believe you or did they think you were crazy?
Well, good question, Teresa, because when I first started doing this, first of all, when I went to work at a nursing home as a nurse, I thought my life was over. I did not ever think I would work in a nursing home, but I was so wrong. I learned so much and grew to have a passion for this. So when I started doing the mental health piece and really spending time with patients, residents, for more than just 5 or 10 minutes, I realized I didn't know much about dementia. So I started taking classes, courses, certification, and then I took some train the trainer. And I was a trainer for other kinds of models of dementia care as well, and started training the staff. And then I came across Teepa Snow's model, and that's the one that I really feel like has made a difference, both in my practice in working with people with dementia and also teaching other people. So I was teaching the nursing staff, so I was a combination of the mental health person as well as their dementia specialist and their dementia educator. And we did trainings, we did week-long trainings, tried to make it really interesting and fun and creative. And I really enjoyed it. Many of the staff liked the model and liked learning and picked up on it. But I also found that, we get into habits. And especially as an old nurse, I know how to do things. This is the way you do it. And I've been around a long time. And I kind of found that resistance from staff sometimes about changing. It's really hard to change the way we do things because we develop habits. And unless the administration, the management really makes it a point to say, we're going to do things different, we're going to do things this way, then people continue to do things the same old. And how they provide care really makes a difference. What we see is people doing to people a lot. They get into this role of being the caretaker and having to do things. So I became very kind of frustrated that I wanted to make a difference. I wanted to change how we provided care. And I like that word how, because that's the key, is how we do it. And I wanted to make a difference, but it just wasn't moving the dial. It wasn't changing how in this care community they were doing it, but I knew it worked and I knew it could make a difference. So that's where I was at when I was there. It just didn't quite change things the way I wanted it to.
Yeah, I know exactly what you're feeling. I remember teaching a class. I was in a memory care, and I had lots of they're like nodding their
Aha
head,
moments. Yeah, that
lots
the
of
light
nodding their
bulb goes
heads.
off.
Yeah, and I felt like they were getting concepts, but then I don't feel like there was time to go apply it. And I remember even saying to a company that wanted to hire me to come in and train, I said, "Here's the deal. If you aren't going to incorporate this into every day um, for your unit, you may as well just send me a check and we'll just be happy
Right.
about it." All right. Because I can come in and teach all day, but if first thing Monday morning, one of the concepts that I taught, if you aren't incorporating that into your rounds in the morning, like today, everybody, we're going to approach from the front this week. We're going to get everybody on board with a simple concept. They lose peripheral vision. Can we approach from the front? And I told them, unless this is a part of your team or unless you allow me to train your trainers, you might as well just write me a check, because you're checking a box that maybe the state's requiring, but you aren't really in the long run helping your residents. And I also remember a gal saying to me, yeah, that's all good and fine, but sometimes you just have to do tough love with these people. And I thought, oh, gee, I didn't break through the ice on her. She had been hardened over the years of not having techniques, and therefore it made her feel like there was no other way but to do forced care. And so it's certainly on my heart, and I feel it on your heart, that there are lots of better ways to do it than doing forced care.
Uh,
Good.
yeah, I agree with you, Teresa. It's really about, so how do we change practice? How do we do this to help people change? I mean, I have a heart for helping people. I have a heart for helping people to learn, and I just wasn't. I felt like I wasn't being effective. So I was involved in a geriatric scholars program, and it was a 10-month program. I learned a lot about geriatrics, and I had to do a capstone project. And I did some research on what makes an effective dementia training. Specific words, what makes an effective dementia training? And I learned a lot. And I'll tell you, one of the key things is having that experiential kind of learning where you actually get to experience what it's like for a person who may have dementia, and have those aha moments, right? Oh, that's why they act that way. Oh, and then we add to that how to do things different. How would we change the way we practice? So I found that that's really important, along with learning new skills. So that's kind of what I learned in taking this geriatric scholars program, and I was trying to implement it where I was at. But like I said, it just they just weren't interested in it. I couldn't, management, administration just didn't want to buy into it.
And isn't it remarkable, if you look back of how we've trained professionals, first responders over the years, it just might be a video, and incorporated into dementia care is mental health and psychiatric nursing. It may just be an hour or so of education they're getting from a video, and you're just my heart just sinks, because this is such a specific need, and there's so much more to it. And like you as a seasoned nurse, me as a seasoned nurse, getting kicked out of my mom's house, I thought I understood dementia too. But what I realized is that there was so much more to it. What have you found, in the nursing college? How did you feel like they were teaching there?
So what I'm doing now, I left that care community. I felt frustrated and I really wanted to make a difference. So I left there and I had a conversation with the chair of the nursing department at Longwood University. And she said that the nursing students, when they go out to their geriatric psychiatric rotation, for clinical, they say they don't feel comfortable talking to patients that have dementia. And I said, I have something for you for that. And so I incorporated the capstone project I did was a 6-hour dementia skills training, experiential dementia training. So we set it up that I'm an adjunct faculty at Longwood, and I provide them with a kind of like a workshop before they get out to clinicals. We do, every nursing student does a 6-hour workshop with me on dementia care and dementia skills. And it's based on the Positive Approach to Care by Teepa Snow. And we learn about dementia, but that, just learning the diagnosis and the pathology doesn't give you anything about how to understand what the person is experiencing and how to interact with them. And so we have trained 224 nursing students at Longwood University. Yeah, 224, 4 cohorts of nursing student classes are going to be graduating with this specific dementia training and the positive approach to care. Very, very happy about that. And they love it. They got it. And then they go out and work with patients and actually can put it into practice. I also then went to the University of Virginia and asked about teaching their nursing students. We did it a little different there. I was hired on as a clinical instructor to take groups of students to a memory care. So it's a smaller number, but I'm with them for 6 weeks each. And we learn lots of topics, and we kind of learn as we go in caring for people with dementia. It gives them a really broad perspective because, like I said, we learn a lot. Each week we have different topics we cover, and they have to write journals. It's amazing how much they learn just doing this. It's all that stuff we talk about in terms of culture change and the things to look at, how we provide care, how we understand what's going on with them. The behaviors are really communication from what the patient can't tell us in words anymore. These students are actually seeing it and doing person-centered care. They're talking about how dementia really requires person-centered care. I know, Teresa, I'm seeing the smile on your face, and it warms my heart to hear what the students write in their journals and how they're really getting it. So it's a different way of teaching with them, being right out there, coaching them in a clinical setting. And, I really believe that that's the way to go now in terms of changing things. I'm only one person, so if we can change how nurses provide care, if we can give them a different perspective, then we can really move this in a different light in the future. We have to do something different in how we provide care. And I really believe this kind of experiential model of learning and learning skills and practicing skills is a must in terms of nursing education. So I'm also at a point where it's like, well, we need to put this in curriculum. This needs to be in all nursing curriculum. So
Absolutely.
That's kind of where I'm focusing. In addition to teaching, that's where I'm focusing my next direction is in curriculum change.
Yeah, absolutely. And it's interesting. As an old nurse, I can remember the first time I noticed brain change in somebody, and it's startling. So I can see why people are afraid to work with people with dementia or with psychiatric challenges. I remember being in a home with a gentleman, and he started repeating himself, and we were just circling this tree with the same conversation. I was giving him the same answers. He's given me the same questions. And I think, I'm a very patient person. And we circled that tree about 7 times. And then I thought, I got to get out of here. I was like, wow, what is this? And why is he stuck in this spot? And so I remember saying, I'm going to check and see if the dishes need to be done, just because I felt like I needed to get away from it. And I didn't know what to do to make that better or to redirect that. I had no idea what to do. And I was a pretty seasoned nurse at that point. I don't remember learning any of this, Marion, in nursing school. Of course, it was a long time ago. But, it makes me think, of all the other areas where this needs to be taught, not just in nursing, because we are afraid of these people. I've talked to people in the ER, and I worked in the ER a long time. And sadly, when these folks come into the ER, if they're experiencing pain or fear or anxiety, they tend to act out. Their language and cognition is damaged. They act out in what comes off as inappropriate ways. Maybe they're hollering
Right.
or just cussing or something
I see
like
that.
that. And we typically just medicate that. And I think that's where we really have to change too the way we're doing things. But
I-
you've opened the door. You've opened the door on education, and I just want to be someone who promotes this because it's exactly what we need. It's exactly what we need in medical school, too, in
Yeah,
our
I
first
agree.
responder education. I'm dying to hear a couple of stories from your students. What were some stories that just you just were like, exactly, that's what I hoped you would see?
Well, one student, just I loved the way she said it. My eyes are opened. My eyes are opened and I cannot look away. This needs to change. It's like they saw it from a different perspective. The what you described was beautiful, Teresa, about that not knowing how to interact with somebody that has dementia, not understanding what just happened. Why aren't they understanding? I just told them the answer. Why do they keep repeating it? When we don't understand it, it almost becomes like this alien, like I can't understand them anymore. And then we try and we don't want to say something wrong. We don't want to make it worse. And so we just want to run away. I think that is so typical of most of us. And then we go learn about it and we learn all this pathology and all this details of disease. And so then we look at the person as diseased. Well,
And we want to
there's
fix
something
them.
wrong.
Can I
And
fix them?
well, and we also want to try to help them change. And so what we do is we talk and tell them what they need to change. The interesting thing is dementia, most diseases of dementia, diseases of the brain, dementia is just a global term for over 100 diseases that affect what's in your brain, nerves and chemistry. That's it. And blood vessels. That's what's in your brain, nerves, nerve connections, neurons, chemistry, and blood vessels. And so those are the kind of diseases that we have that are affecting all of those. It really doesn't matter what is causing the damage. It's that it's being damaged. So what we end up seeing is the result of that damage. And that includes language changes, reasoning, memory, vision changes, their visual field, movement and abilities. That's where we need to focus our understanding and learning and on what their abilities are and what their what's changing for them. That's the kind of education that I'm trying to focus on, not so much the pathology and the disease process. So what's different in the students and what they're learning is that they're really in there seeing the person now.
Mhm.
Through the disease, through the dementia, they're not seeing just the dementia, they are seeing the person. It's just a different way of learning. I've had students write amazing person-centered care plans. I mean, that seems to be a hard thing to do in put it into play. You know, we talk about it, but then actually applying it in practice. So I know that this kind of model is working for students. So
I love it. Well,
um,
I can think of a resident that I had who things went haywire at the memory care and she got sent out. And obviously a place where I needed to go do more training, but she got sent out and she at least went to a hospital that had a really great Jerry psych ward. And I thought, well, it's a small place. They have a great physician, you know, she'll get good care there. But you know, the emergency room labeled her, you know, as maybe a psych patient. She never made it to their wonderful. She came from a memory care unit. She ended up on the floor with antipsychotics. And so I can just see how this problem is huge out there, Marion, and we have so much work to do.
So what you're describing is how when we see these reactions, how people respond and try to communicate with us, we look at it and we see a psychiatric symptom. And then we try to treat it like a psychiatric symptom, when really it's just a way that they're trying to communicate, because we're a society of language and reasoning. We use language to communicate and reasoning to get our point across, which is what we're trying to do right now with healthy brains. With dementia, most dementias affect the areas of the brain responsible for language and reasoning. And yet we try to interact with that person who's got language and reasoning problems, and we hit it with language and don't you understand? And it's not working. It's not getting through, because as the person's disease progresses, they no longer can connect their own nerves with itself to explain, what am I feeling, and I got to go to the bathroom or get out of my way. And so then they react to that. And we see it as a psychiatric symptom. Let me give you an example. So I saw this one woman. I noticed she sits like this in a wheelchair and she has her one eye closed. That sounds like she might be a little more advanced with her vision field is really narrowed, and she may be having trouble with her brain, doing the whole thing. I see two images, I have to converge them and flip it. Well, if my brain is not working and not doing all that, I may see double. So what we see is the person may be closing one eye. So she's sitting there in a crowded room of 15 people, tiny little thing, and people are talking, and somebody comes beside her and says, we're going to take you to the bathroom, and immediately begins to move her chair. That someone was beside her, behind her, so she wasn't seeing her. So all of a sudden, she wasn't noticing that she was talking to her. All of a sudden, her wheelchair starts to move, and she starts shouting, wait, wait, wait. And they said, she needs something for anxiety. And I thought, my gosh, she didn't see you. She did not even see you. There's so many examples of that, where when we observe this kind of what we call behavior, we label it with a psychiatric symptom and then try to medicate it. Nothing's going to fix this thing where she gets startled. You come up to her and start moving her chair and her whole equilibrium is off. Nothing's going to stop that from happening. A medication is only going to make things worse. So there's lots of examples of different kind of situations. A person who is wandering into other people's rooms, they have trouble initiating an activity. Walking is an activity. Walking is the easiest thing we can do. We just get up and we move, and we are made to move. And so they walk and they look, and they're finding things that they like to see. And it may be in your room. It may be in your office. It may be stuff they like to take. And then we say, no, you can't do that. And then we hit up against this language and reasoning thing, and they don't like it because they don't understand. And then we're in big trouble with some aggressive behavior, resistance. And that's when the person gets sent out, because they can't be doing this in other people's rooms. When if we had just figured out, hey, they need something to do. Let's find something he likes and give him some activity so that he's not going into other people's rooms looking for something to do. You're right, Teresa. The issue of medication, my students and nursing students really see that part. And I'm so happy for that, because I don't want them to be the nurse that says, give them some Ativan. She has anxiety. She needs medication. They are seeing, and they're asking this question, why are we doing this? These medications aren't working and they're not good for them. There's lots of bad adverse effects from these medications that people need to be aware of. And that's another discussion to get into about medication. But so if we can understand their perspective, recognize her vision change and say, I need to get in her visual field and go a little slower, tell her in a way that she'll understand that we're going to the bathroom, this won't happen. And it's really that simple, and it does work. And what I'm finding with the nursing students is they begin to practice it and they do it. And one student said you asked for an example. She said, I'm finding myself actually doing the skills before I even realized I did it. Yeah. It's becoming the habit. So we want this to become the nursing practice. So that's how I see going forward to change how we provide care and changing practice with the nurses of the future. And I
Yeah.
tell them, other nurses out there, they don't know this stuff. They're doing it different. They don't realize they just moved her chair and she's startled because she didn't see them. They don't know that because they didn't have this education yet. But we need to give them grace and we need to teach them. And so these nurses that I'm teaching, I'm counting on them getting out there and being more of a teacher to other nurses. So that's how I see things going forward with the future of dementia care and nursing. We have to change the culture around dementia care. That's obvious. Nobody's happy with what's happening in nursing homes. We have to change it. It has to change with nursing. It has to change with nurses. And this is one of the ways to do it, is how we provide care, teaching them a different way to provide care with nursing students in nursing education.
So, and what I'm feeling, to summarize, I can hear Tipa when I took her training, one of my mentors for sure. When I can hear Tipa saying 70% of the behaviors are caused by the people around them. And so it's like, oh, geez, that's so unfair. That's so unfair to the patient, that we just don't know. But we can't beat up the student if the teacher's never taught. So I love what you said about grace. And it seems like what's different, Marion, about what you're doing is it's not didactic learning, it's experiential. And you get the ability to teach skill and then take them into that environment and let them experience the positive effects of changing the way they do things.
That's exactly right. Nursing curriculum and med school curriculum, I think med schools use a lot of case studies nowadays. I learned that from my experience with the geriatric scholars program, but a lot of nursing education has about 2 hours of education in their entire BSN 4 years, 2 hours of education on dementia, and it's primarily didactic. In other words, they get this lecture, they have this to read, and it's primarily diagnosis, types of dementia. They hear about behaviors and they call them psychiatric and behavioral symptoms of dementia. And then we say, well, behaviors are communication. And we immediately jump to labeling them as a psychiatric symptom. And then the next thing to cover is the kinds of medications we use. So what pieces are you putting there together? It's like diagnosis, psychiatric, medication. And that's how it's viewed, not something that the person is experiencing and how to connect with them. I titled my training Getting Connected because it's all about connection. It's all about connection. And, what we teach makes a difference as well. So that's the difference here. What's normally in curriculum is didactic. And this has to be taught different if we're going to move forward. And we will.
We will. I think the ball is rolling. This tidal wave, I keep talking about the tidal wave. I'm so excited. I'm so very excited about what you're doing. How can someone get a hold of you if they want to learn about your curriculum and bringing that to their city? Marion, how do they get a hold of you?
Well, I don't have it on the screen here, but they can just email me at marionkyner@gmail.com. That's one way. I'm on staff or faculty with Longwood University, as well as the University of Virginia. You can look up their staffing and find me on there as faculty as well. So yeah, that's my Gmail. So you can just email me and I'll be happy to talk to anybody, especially nursing programs. I want to make this a movement across the country.
Yeah, and we need it. I appreciate you being here so much, Marion.
Thank you
This
for
has
inviting
been
me.
just so fruitful. I think that, we're going to just keep working hard to get this out there because there is And, the person centered part of what you do too is so vital. And because we need to see these people as they are, individuals, my mom and your dad, these are individuals who had a life, who had a career. There's somebody in there, and we can find that somebody. We can learn what they like and don't like. Boy, it can completely change their care. We can figure out if they're in pain or not. I can just see so many great things coming out of your training. All right, everybody. That wraps up episode number 3. I mean, so much great information here. I think you might have to watch this one 2 or 3 times. Great speaker, Marion. Thanks for being here, sharing your wealth of knowledge. You guys, reach out to Marion Kyner at gmail.com if you need more information. I am going to be working in Ohio on getting this information out there because I think it is vital if we're going to change the way we love and care for people who are experiencing brain change. Okay, thanks everybody. That's episode 3 of Memory Care with Teresa. Just remember, you got this.